Hello and good afternoon to our audience members. Thank you for joining this session dedicated to exploring interventions for treatment and recovery stigma. As a reminder to our audience members, we welcome your questions for an audience Q&A, which will close out this session. You can submit your questions in the submission box below this live video. This session is approved for CE credit. Instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon. With that, I would like to introduce our panelists for this afternoon. Dr. Corrie Vilsaint is a principal investigator at the Recovery Research Institute and Center for Addiction Medicine and a research fellow at Massachusetts General Hospital and Harvard Medical School. As a community psychologist and nationally recognized speaker, her research focuses on racial health equity in remission and recovery, reducing recovery-related discrimination, building recovery capital, and the effectiveness of recovery support services. Julia Lechuga has over 15 years of experience assessing the needs of BIPOC individuals afflicted with substance use disorders in the US and Central America, and developing, implementing, and testing behavioral interventions aimed at reducing rates of infectious diseases while addressing needs. Dr. Lechuga graduated from the University of Texas at El Paso with a PhD in health psychology in 2008 and completed her postdoctoral fellowship at the Medical College of Wisconsin in 2010. Her interventions address factors at the policy, community, and individual levels. Presently, Dr. Lechuga is Associate Professor of Public Health at the University of Texas at El Paso in the College of Nursing and Health Sciences. And it is also my pleasure to introduce the moderator of today's session, Sean Fogler. He is a co-founder and consultant with Elevyst and a physician living in long-term recovery. Sean has worked on several projects in Pennsylvania to expand naloxone distribution, medication-assisted treatment in correctional settings, and syringe service programs. Most recently, Sean has worked with the ACLU to form the Health Justice for Pennsylvania Coalition, which aims to highlight the intersection of substance use and Pennsylvania's criminal legal system and provide policy reform recommendations guided by the philosophy of harm reduction. Sean has worked closely with the Pennsylvania Sheriff's Association, the National Sheriff's Association, and the Centers for Disease Control to provide technical assistance and develop, deliver, and evaluate harm reduction training for law enforcement professionals that aligns public health and public health safety goals. Sean currently works with RIWI, a global trend tracking and prediction technology firm, to explore and reduce stigma towards people who use drugs, those with substance use disorders, and those in recovery. Sean is active in the recovery community and facilitates a weekly physician peer support group with the Live Well Foundation. In addition to his work as a public health consultant, Sean volunteers as a peer support specialist for lawyers concerned for lawyers. Sean, would you like to get us started this afternoon?
Sure, thanks so much, Robert. And thank you to Shatterproof for hosting this, this really impactful session. So as we get started, the first question I'd like to really explore is reimbursement today. You know, since 2008, with the Mental Health Parity and Addiction Equity Act, and in 2010, the ACA with the expansion of reimbursement for treatment and recovery supports still is quite a challenge. So the first question to the panelists is really what does reimbursement look like today? What are we paying for? What are we not paying for? And how does that drive stigma and impact access to care and delivery of care? Julia, would you like to start?
Absolutely. Well, unfortunately, I think that the stigma is a prison, right? I think that it colors the decisions that we make around reimbursement. And unfortunately, treatment for substance use disorders are really not where they should be compared to the payment structures for other illnesses. So that is my response here.
Corrie.
Thank you. Regarding reimbursement, one of the bigger issues we face is the Mental Health Parity Act, which guaranteed that mental health and addiction care was covered at the same level for other health conditions. It's not happening. The Parity report to Congress released in January makes it clear that none of the major insurance carriers are in full compliance with the law. Meanwhile, this country is in the throes of the worst addiction crisis we've ever seen. And the vast majority of individuals who do not get the care they qualify for. So as we're watching 300 people die a day from overdoses, we have the opportunity here to change the tide if we enforce this law. And regarding recovery support services, the one I like to highlight regarding payment sometimes is recovery housing, because this is an empirically supported service in which many residents pay their own rent. So not every service requires an external payer, but what the service does need is federal housing rights to be protected. Thank you, Sean.
Right. Yeah, I mean, as a person with lived experience who's been to treatment, I think the real work starts when you leave treatment. Obviously, we want, to improve access to treatment, but what do we do after that, and how are we supporting these recovery-oriented systems of care, which are critically important to keeping people in recovery and putting them on a path to health and wellness. And I'm not sure we're investing enough in that. It's unfortunate that we have to enforce this, in that way. But it seems to be the only path forward. Are there any other things you can think of in terms of educating policymakers or things that we can do that will improve the investment in treatment and recovery and get insurers on board to pay for this like they do for physical illnesses?
Unfortunately, lawsuits appear to be one of the only useful mechanisms that we have for parity right now.
Thanks, Corrie.
Yeah.
So the next question really is, we have this broad spectrum of addiction treatment and recovery. I also include, harm reduction in that spectrum. I'm not sure everybody's on board with that, but I think it's important to include it there. So how are, I guess, different facets of this spectrum of recovery stigmatized in healthcare by policy professionals, even the general public? Like, what does that look like? How is that impacting our delivery of care, going forward? Julia, do you want to start?
Sure. So, I think that beginning with the way that we treat substance use disorders, it is really treated in a separate way from other healthcare. We separate it, right? We treat addiction in a separate way compared to other diseases, and it should be integrated. I think that definitely plays into the stigma. And even when we think about the places that are specialized to treat substance use disorders, we see that many are also perceiving or feeling stigma towards certain models of treatment, such as, for example, methadone assisted treatment. We see that places that, like this fight between the abstinence only model compared to other forms of treatment. So I think, starting there, looking inwards and understanding how we are perpetuating the stigma even within our field. I think it's something important to begin to stigmatize.
Corrie, anything to add there?
Sure. Regarding how recovery is stigmatized by healthcare and policy and professionals, and in particular, the general public, starting there. Well, discrimination can occur when you're part of a stigmatized group. And it's common among people already in recovery. Now, what we call micro level discriminations occur on an interpersonal level. They involve personal slights, derogatory statements. In fact, at the Recovery Research Institute, we found 47% of people in this country who've resolved a problem with alcohol or other drugs said that others assume they were likely to relapse because they knew about their history with alcohol or other drugs. 20% said they looked like an alcoholic or addict. 28% said they were ignored by people because they knew about their history. And 31% said people assumed I couldn't provide for myself. And now that was kind of examples of micro level discriminations that occur with the general public, and the frequency and the prevalence by which we know that it occurs in people in recovery. But we also have macro level recovery related discrimination, which is how structural factors on an organizational or a systemic level, like policies, can be used to violate the rights of individuals even after they resolve a problem with alcohol or other drugs, because someone knows about their alcohol or drug history. Because of laws in the US, the use of many substances is a crime. And the consequences are arrest, conviction, incarceration, loss of rights and services. Yet individuals who commit other crimes, including violent offenses, can often retain their eligibility for services like housing and nutritional assistance. That's why we call this discrimination. So in our national study of people in recovery, we learned that 19% of the people in this country who've resolved the problem with alcohol or other drugs report being treated unfairly by the police because they knew about their history. 15% still report getting inadequate medical treatment. 11% said their insurance would not cover some of their medical costs. Again, that could be because of alcohol exclusion policies. We've allowed these things. 16% said they could not get a job. 12% were denied a loan. We knew that with college education funds, you were allowed to get you were allowed to be banned. Unlike other offenses, 8% were denied the right to vote. But more importantly, people who experience these types of discriminations, it was associated with increased psychological distress, lower quality of life, and lower recovery capital. And so it does matter. Now, we also know that if you were Black, the odds of experiencing recovery-related discrimination was even worse. Black people in recovery were more than twice as likely to report they lost their job because somebody knew about their history compared to their white counterparts. They are more than 3 times as likely to report not being able to get a job, 4 times as likely to say they had a job but not a promotion, and 3 times as likely to say they were denied housing because somebody knew about their history with alcohol or other drugs. But those are some examples of the structural components. They need to be investigated for their negative impact on recovery and for their disproportionate impact on individuals who identify as Black. And part of that's how we change the narrative to focus on what our institutions are doing to magnify harm from disorder as opposed to minimize harm from disorder.
Right, and it really is every system. It's these layers of stigma. Whether it's race, whether it's that you're in recovery, if you're an immigrant, right? The collateral consequences for a drug conviction, obviously criminalization. These are really, really important. One other thing, just to shift gears, is what about the investment in short versus long-term treatment? Because historically we've had this idea of short term, and I think it's what we were willing to invest in, right? A couple weeks in treatment, you go to detox, and then you're back out into the world, right? Now we're kind of 28, 30 days, but it seems that there's more and more research and evidence to support longer term treatment is more effective. I know in my case, I went away for a few months, and I always say, like, the smoke just began to clear after a few months. And so, is that a big barrier? And I also know, with health professional programs, right, we have this extensive kind of 5-year model. which has a very high success rate, right? But the rest of the population doesn't really have access to that. So what are your thoughts on that? You know, is that achievable to really push for some of those longer term treatments? Does that make sense?
Yes, I can tell you that, you know, that kind of, in a way, that reminds me of how healthcare systems sometimes need to change their mind around these, around addiction treatment. You know, historically, we did treat substance use disorders with this kind of very episodic approach: medical detox, clinical stabilization, a brief form of treatment. But we know it takes about 5 years of continuous sobriety before the risk of meeting criteria for substance use disorder drops below 15%, which is when you're no more likely than someone in the general population to have a substance use disorder. So eventually, now we started treating disorders like a treatable yet chronic and persistent disorder, which called for this continuing care paradigm or recovery management approach. And so we've been able to extend the continuum of care using recovery support services, like certified recovery specialists, collegiate recovery programs, recovery high schools, recovery housing, recovery community centers. And this is reflected in our science, where we started testing recovery support services on the continuum of care, knowing that these long-term supports are absolutely needed and reflect the duration by which it takes somebody to, it might take somebody to get through. So, yes.
Yeah, and I also think it's important to just recognize the vast majority of people either don't have access or want to engage in treatment. And so it's important that we have strategies to deal with the vast majority of people. And I think that's where, you know, harm reduction can fill that gap. Julia, did you have any thoughts on that last line of questioning?
You know, it just following from what you just said, Sean, I think we need to start with reducing the self-stigma, right, that individuals feel towards substance use. And, you know, it's interesting, in other parts of the world, we see, like, for example, in Australia, we see public service announcements around not substance use, but mental illness. And I think it's something where we're lagging behind. And it would be ideal to, collectively, start thinking about what can we do to reduce the self-stigma, because everything, in order for advocate for you, for your rights, for yourself, you need to believe, right, that you're worthy of it.
Yeah, I think that's really important. And I think early on when Gary Mandel kicked this off and he talked about his son and the shame and the dehumanization, and that's clearly he has an understanding that that's what really, you know, took his life. And that self-stigma, like that toxic shame, is incredibly destructive. And I think, you know, obviously people with lived experience understand that at a really deep level. That's why it's one of the many reasons why it's important to have them kind of driving these conversations and creating policies that address that. So are healthcare professionals that that care for this population today stigmatized, like within these systems? And are there, you know, how does that impact their ability to deliver, you know, care in these systems? Either of you are, you know, welcome to answer.
Sure. It's, you know, what I want to say here is that it's unfortunately, I work with a Latino population mostly, and most of them are Latino immigrants, and we have very few providers who look like Latino immigrants providing these types of services, and much less for substance use disorders. But, you know, it's something that is not well understood to the extent to which ethnicity co-varies with, the self-stigma that people might feel. But in my community, what I have to say is that, you know, we have to do an intervention for healthcare providers, even those who are, who are in the field. Their practices, I have to say, are a little could benefit from improvement when it comes to, you know, enacting stigma towards others. So I wish, you know, that we could have more research on this line with interventions with providers.
Corrie?
Yeah, you know, regarding the stigma that the workforce may encounter, you know, that can be real. We know going back historically, traditionally, mental health, substance use disorder services were traditionally separate from mental health and general health. You know, here, why is that? That's because of stigma. AA emerged because mainstream psychiatric and general providers did not attend to substance use disorders. Even in the 70s, addiction was viewed as a social problem dealt with through civil and criminal justice. And so the healthcare system at that time, they were not trained to care for addiction, and were not eager to accept addiction patients. And that's when thousands of locations were built up for treatment, they were only for withdrawal management. And in hospitals and all other programs were geographically, financially, and culturally separate from mainstream healthcare. And as a result, it really reinforced the notion that substance use disorders are different from other medical conditions. And mainstream healthcare failed to recognize substance use disorder related health. As a result, it created unintended, enduring impediments to the quality of care. Healthcare professionals deal with the consequences of this to this day, which in part explains why our field tended to have less formalized language than the rest of the medical field. We hear things like you have a dirty test as opposed to you have a positive test. You might hear practitioners say a patient can't be trusted as opposed to a patient is symptomatic or experiencing a recurrence of use. So we have a very moralistic language as opposed to a medical language around this profession that reinforces stigma, but explainably came out of isolation, separation, and segregation of this field.
And I think that was reflected also in the training, because there really was a lack of training. Even today, it's a bit of a battle. It's happening more, obviously, around the country, but to integrate that training into the curriculum, right? We don't have time for this, but like, what's the alternative? I mean, this patient population is growing, and they're everywhere. And it's interesting. For a while, I was on this committee at a large academic hospital, and they didn't want to open an MAT clinic because they were like, we don't want to attract that type of patient population here. And a number of clinicians were like, they're already here. Like, but they didn't want, you know, that group to be exposed to their other patients, which were looked at differently because they thought that would impact the business, you know, and they didn't want that, which obviously is, you know, is really unconscionable. One of the other things I think about it is that many addiction medicine professionals or professionals that care for this population are in recovery themselves, right? And in medicine, obviously, there's this culture of silence. It's not always open, but I know, like many colleagues that are doing this work, and I wonder, like, do either of you think that might be a barrier internally to these systems, right? You have like a person who was, you know, quote unquote, an alcoholic or an addict before doing this work with these patients. And, you know, maybe the perceptions of them and that group are driving like some of these barriers. Is that far-fetched? Does that seem like?
No, I think it goes back to the self-stigma, right, that we were talking about, and how that permeates everything, really. But, you know, Sean, not to steer away from the question that you asked, but I wanted to just follow up briefly on what was said before. You know, we did a harm reduction behavior change intervention with substance users on the US-Mexico border. And we had a community advisory board where addiction specialists, MDs, participated. And at the end, we conducted some focus groups with them. And it was, you know, just participating in a harm reduction intervention created greater sensitivity on their part, and you know, they openly said this for the way that they treat their patients, and to me that was just incredible. And it goes back to the training, right, that we're saying, the training that you receive, then how the institution that you work with continues to perpetuate this stigma. But yeah, that's I just wanted to follow up with that. Not to
do you
detract
think,
from the question.
no, it's, I mean, it's all related. Do you think
Yeah.
training in trauma-informed care
Oh,
is
absolutely.
impactful? Because I see addiction is rooted in trauma, or
Oh,
mostly rooted in trauma.
absolutely. You know, I think there is this tremendous need to do things like that, even if these are brief interventions, even if these are short engagements. I think we need to start this and do it in a more conscientious way to, you know, to kind of get us there.
Corrie, you look like you're about to say something.
Oh, no, I think what she said when those able to talk about intervention work is spot on. Thank you. We'll leave it right
Yeah.
at that. Yeah.
And I'm sure you all know Gabor Mate well, but he talks about that, you know, the roots, you know, of addiction being rooted in trauma and pain, and addressing those underlying issues. Like, a lot of our approaches are very surface level. They don't go deep enough. You know, a little bit of treatment, you know, is not necessarily the answer. We need all of these things. You know, we need multiple strategies, but we really need to go deep and address like that shame and that underlying, you know, psychosocial disconnection, to really like bring people out of the shadows and into the light. And that's, I mean, that's a danger of stigma, right? It keeps things buried. And so I'm going to shift gears a little bit and talk a bit about medications. So why isn't you know, we know medications for opioid use disorder are super effective. They save lives. We have tons of data from overseas. We have data here now. Why is there still resistance to medication in recovery circles, different organizations? I mean, we know in the criminal justice system, we're just starting to move the needle in that area. Why the resistance to a medicine that we know works for something that most of us are coming on board and recognizing as a disease?
Okay.
So
I'll start.
oh, go ahead.
All right. Yeah. Well, there's probably more than one reason with that, but I think there's also one belief that you are substituting one addiction for another when you take methadone or Suboxone as prescribed, because they contain small amounts of opioids in them. This is a similar approach to using a nicotine patch, though, as a smoking cessation aid. These are highly effective approved medications, and the data is clear. They are life-saving treatments that block the effects of other opioid drugs. They reduce craving, mitigate withdrawal symptoms, prevent lethal overdose, and increase remission rates. In fact, we know, looking at 5-year trajectories, show us that 60% of people experience very low levels of substance use or steadily decreasing levels of substance use compared to their levels of substance use before using the medication. It's like night and day.
Julia?
Yeah, I want to put this out there. You know, I feel that also the not accepting totally. I think this is a big elephant in the room. We talk about it all the time, that substance use disorders are a chronic illness, are, you know, it's a disease of the brain, and we still don't accept it. I think it goes back to that. We still don't fully accept that view. And within, you know, the formal healthcare settings also. And I think that definitely permeates the way we treat it and the way we separate it, as Corrie was saying, right? It continues to be separated. It's not yet there where we want it to be, in spite of laws and policies being in place. So how can we deal with this big elephant in the room right? How can we start stigma reductions, interventions, so that we start to accept it?
Yeah, and I always think about this as a healthcare professional. Um, is it even possible to destigmatize this medicine when our, professional health programs stigmatize the medicine itself and don't allow, for the most part in most states, allow a healthcare professional to hold a license and take a medication for opioid use disorder that we know works, right? That we have plenty of evidence. So, how does that impact the way we think about this, right? Because our people, healthcare professionals, are going to look at it and say, well, you're still damaged, quote unquote. You're still sick. If you take that medicine, you can't actually work. It's going to be very hard, right, for us to change the way we look at that medicine, the people that take that medicine, and really probably fuels like our perceptions that these are flawed people. They're not like us. They're not part of our group, right? They're dangerous. They're a risk. All the things that we know, right? All these different attributes that drive stigma. And I think this, and it goes for all, this goes for like pharmacists and nurses and all the other healthcare professionals. And we know, there are plenty of, a good proportion of pharmacies won't carry this medicine. They won't even distribute naloxone. I think things are shifting and improving. There's definitely hope, but a lot, it's like our drug policy is embedded. The drug policy that exists in our criminal legal system is embedded in our healthcare system, right? And is doing a tremendous amount of harm. Any thoughts on that? I think things are changing. I don't want to paint like such a gloomy picture, but it is what it is, right? Corrie?
I think that was perfectly said. I think that was perfectly said. Absolutely. Yeah.
Julia, anything?
Yeah.
Anything else to add?
I think you said it beautifully.
And how, what about the impact on pain patients? Our drug policies and the way, I guess, things have shifted with addiction and the way we manage addiction, because that's a patient population, I think, that has really suffered and has experienced a lot of harms because of how we look at people with substance use disorders.
Yeah. Yeah, absolutely. I think that population has suffered because, we really fail to distinguish. Pain patients, for example, here we have a group of people who are taking medications as prescribed. Okay. And when you do that, sometimes one of the side effects of the medications is physical dependence. That should be interpreted as a side effect of the medication, not addiction. We know better than that now. We know that is not addiction. And so we should not be pathologizing pain patients who are taking their medication as prescribed.
So what's the public perception of recovery success, I think? And how does that drive stigma? And how does that perception compare to the reality?
Yeah, I think that we're, if we would think of harm reduction possibly permeating the systems where we give an applause and a shout out to somebody who does a little change, that would be amazing. But no, I think still success is measured as abstinence in many places. And why? I don't think we do this for any other condition, right? When we're trying to lose weight, when we're trying to do any other, behavior change. But in this area, that's what we expect. Otherwise, you're not being entirely. And I think, I say this because we conducted some research, some in-depth interviews with people who were currently taking methadone-assisted treatment, methadone. And this was the belief even within individuals who somehow embrace harm reduction. So again, it's something where I think we need to do something to intervene and understand what real success and put it out there might mean for different people.
Do you think it's possible to, I'd like to think it is, but do you think it's possible to embed that philosophy of harm reduction within our traditional healthcare system, like this idea of incremental change, like any positive change kind of defined by the individual, not by us, in that kind of paternalistic way? Because I mean, frequently, it's like, hey, if you do these things, then you're worthy of care. And if you don't, get out. And I
Sean,
mean,
yeah, I wonder, and I ask you as a formally trained healthcare provider, because I've seen providers, once you understand it, once you're really literate about it, that it makes sense and you want to embrace it. But I think, somehow it's at odds with the training that you receive. So I want to turn it back to you and ask you, what do you think, and how can we get providers on board?
yeah, I mean, I think it comes down to, and it's funny because I do a lot of training with law enforcement, and this might sound outlandish, but the attitudes in the law enforcement community are just like they are in healthcare. And nobody might really want to hear about that because, our healthcare systems where we should receive compassionate care. But when it comes to substance use, drug use, it's not there. I think education is important. I think one of the things that Dr. Crendel said earlier about, and I talk about this all the time, is closing the social distance gap, like bringing people with lived experience, not just, this idea of tokenism, like tell your story, come, but actually, at the table, making decisions, like driving policy. I mean, even the way we treat healthcare professionals that struggle with substance use disorders, right? We isolate them, we disconnect them, we shame them, right? We do all these things that are really, really destructive. And we have to change that. Like, we have to change that culture. I think education's a start, but it's like, we talk about language, it's really important, but I think that's like low-hanging fruit. I think part of it's having like real conversations like this, actually speaking openly about it. But I think we have to come to a place, we have to shift the way we see people with this disease, because the way the lens we've been looking at them through is super destructive, and the healthcare systems are as bad as, and I know there's a lot of systems doing great work and great people, but what I find is that there's these groups within these systems that are doing amazing work, but they're pushing up against these large systems that don't really want any part of it, or want to distance themselves of it, and keep themselves at arm's length, not just from the programs and the practices, but from the individuals that are struggling. And we need to pull people closer, not cast them out, right? I think. Corrie, or?
Yeah, great point. Historically, addiction treatment leveraged 12-step models of recovery that recommended abstinence. And so although the treatment landscape has started to change considerably, abstinence-based models of recovery continue to dominate. And this means for some, moderated use or taking medication as prescribed while you're in recovery is a stigmatized pathway. And some individuals will be hesitant to engage in care because perceptions that an abstinence-based goal is required. However, abstinence is not always a requirement for resolving a problem with alcohol or other drugs, and may not be the only priority for people seeking treatment. In fact, abstinence is not even a requirement for medical remission. The diagnostic classification system assesses symptoms caused by use rather than assessing the frequency and quantity of use itself. But at the same time, We know that research suggests there are benefits to abstinence, including a more stable recovery, less psychological distress, greater happiness. And so with that in mind, abstinence may be recommended, but not required, and tailoring recovery goals to a person's needs that focus on reducing harm could be an important strategy to engage individuals to make shifts from higher risk substance use to lower risk substance use.
Julia?
I agree 100% with Corrie, you know, and it makes me think also how, as a field in research and in strategies to reduce stigma, as a field, I think we are not united entirely because we have like this separate area of prevention, which I think is working against us. Right? I mean, some of the models very well known, like the DARE model and these models that are out there for prevention, it makes you think about, oh, you know, we don't want to associate with people, with that group of people who all already, you know, started using. So, you know, tackling that angle too, I think is going to be important. I mean, we're talking about, oh my God, so many things, right? That are needed.
Yeah, when I think of healthcare too, I think of trainees because frequently, like when I get a chance to speak to medical trainees, they're excited about this stuff. Like they are, what do we need to do? Like, and it gives me a lot of hope because they want to change things. They see it. So I think engaging with trainees, providing like education and interventions with these group and tracking them, because we know, right, there's been plenty of research on medical trainees and people in residency as they progress through their training, their attitudes towards this population, they get worse, right? So how do we, at the very least, arrest that? And best case scenario, right, just totally change the culture, because I think the old guard are a little more resistant to those changes, and people are, people are busy, just like in law enforcement and healthcare, people are super busy. They're, even if they have great intentions, they're just trying to get through the day, and they're operating in these systems that have been designed to do a tremendous amount of harm, and I don't even think they realize it half the time. So I think that's important too. And the other thing I wanted to bring up, and Corrie mentioned this earlier, is criminalization. Like, can we really address stigma? Can we achieve like these, significant cultural changes in these systems without addressing the criminalization? Because, if you use drugs, you're a criminal, right? You are a bad person. You are a danger to society. And even I would say, in kind of a, like in addition to that, how we oversee medications for opioid use disorder, right? The fact, that you used to need a waiver, now you file a letter of intent, but you can only see so many patients. There's all these regulations. There's DEA oversight. You got to line up around the block, at a methadone clinic to get these medications. Talk about stigmatizing, right? Lined up, snaking around a building that everybody knows that that's the methadone clinic. We have to, I mean, so the first question is, can we achieve this without addressing criminalization? And then even the way we, prescribe these medications and oversee like medications for opioid use disorder, does that need to change too?
Well, I just want to, before going into that one, just comment on what you said about the providers and the trainees, if I may. I just want to say that, diagnose it, right? Why can't we diagnose a substance use disorder the way that we diagnose other illnesses? As you enter with the provider, now they're asking about all sorts of things now, right? I've gone to my primary medical doctor and I've gotten questions about depression, anxiety, but oh my gosh, substance use, don't even mention it, right? And you even feel tremendous shame to disclose. So I think trainees, if we start just training to diagnose like any other possible, condition, might be something good. But turning to the criminalization, that's, my God, the monster, right? Because I think we derive many of the stigmas through the policies that we have. So yeah, and Corrie, I'll defer to you now on this one.
And I'll just roll right off your back on that. The federal schedule classification of drugs is a cultural agenda that we set. It's not based on how harmful a substance is. In fact, if you go far enough back in history, we know that, all drugs were legal before they were illegal. And when they started to make them illegal, they were targeting certain populations, targeting problem populations. We got to listen when the war on drugs was launched. We have direct quotes now from Nixon's aide saying that this was a racialized approach. He said we couldn't make it illegal to not support the war or be Black. So we decided to go for the drugs because we could break up their communities and villainize them every night on the evening news. It's in our face. Okay. And so this is a system that we inherited. And so we have to dismantle this system. This is why people get pushed to the shadows with addiction, and as opposed to treatment or care. And unfortunately, not at equal rates. Whether you end up in jail or treatment often depends on the color of your skin, which is another problem with policies that are rolled out in unequal fashion. So
I think the other thing that's important to recognize too is that all drug use is not a substance use disorder. And that's something we tend to go with. If you're using something, then you've got a serious problem and you're a danger. I mean, people use drugs, right? From every demographic in all walks of life. And like you said, Corrie, so, you beautifully said it, it really, our approach to drug policy was really to target certain groups of people, and disrupt those communities and destroy them. And it worked, right? And it worked, and it still works today.
Right.
I think, we're gaining more insight. I think there's a lot of people, working to improve these systems, but it's definitely, we have a long, long way to go. With kind of more of a brighter, hopeful end here to our session. Is there an example of a healthcare system, or entity who has made a significant shift in their culture around, addiction treatment, recovery as a health outcome? And obviously recovery, there's a lot of different definitions, but can you think of one, and what are some of the things they did or they're doing? How have they measured success? And I think that's defined by the people, right, that are in the system, like their experience. So can you think of any organization or group that's doing great work?
I worked, this was a few years back, but I don't know if they continue to do the work that they were doing. This was at the Centers for Opioid Disorder in Pennsylvania, but the idea was to integrate it with medical care, with regular medical care, within a federally qualified health center. And so their idea was for patients to come in and, be with the general population and just, receive services like any other. And I conducted a study there on implementation barriers, because there was providers were starting to say, we don't want this, or we need additional training. And there were barriers from within the organization to really sustain the model. And we are in the process of still analyzing that data to see, what are some possible ways forward. But to tell you the truth, I don't know if the model continues, but the will was there at a state level.
Corrie?
Yes, sure. Nice example there, in regarding questions about, well, how do we measure success? We would, depending on who you are, and all we had was negative drug screens, but people in recovery know that recovery is more than just a negative drug screen. Recovery capital is an emerging international construct for the addiction field. It represents the sum total of internal and external resources, strength-based resources needed to initiate and sustain recovery. We know that it helps to mitigate the psychosocial stressors associated with adaptation to abstinence, and it stands in stark contrast with and complements deficit-based approaches that we only tended to take stock of pathology, problems, and powerlessness. But that's just one measure that's starting some uptick. So we can start to move beyond abstinence alone outcomes and capture more of what recovery is really about.
What are some of the most significant, I mean, I have some ideas, but I'd like to hear from you because you're an expert in this area, significant areas of recovery capital that are like, is it employment? Is it housing? Is it like, what are the most impactful, areas to really, for us to focus on? Like if we were to pick 2 or 3 that we wanted to focus on that really could move the needle.
I'll tell you that sometimes the literature still needs to emerge on that really scientifically to do it well. It really does. And part of why, in part, it may be difficult to ever we will make conclusions, but some of the strong conclusions is going to be, we struggle to measure community level recovery capital. Okay. And so as long as we keep having measures that are missing that, it's always going to bias. It's always going to bias what we know. I can tell you that according to even the trials of sober homes, that is a strong body of research. When you are talking about housing, they contend with treatment outcomes. It is strong. So that's one thing I'll leave you with on that. Yeah.
And I've got to imagine different groups, different things will be impactful for different groups, right? And are we doing enough to make treatment, recovery, culturally sensitive, right? Especially, rising rates of overdose deaths, in Black and Brown communities, right, and Latinx communities are off the charts, right? Like you've seen the latest data. And I, one of the things I think about is that these communities have no reason to trust us. So like, how do we build trust? Like, it's hard to do something acutely when nobody trusts you. They don't believe what you say. You've been doing a ton of harm in the community. Like, how do we engage with that community and provide care and help? Because, they're not going to believe us. I mean,
I think that it was mentioned earlier, the peer recovery model, right? I think for me is, in Latinx communities in the US and around the world, we have been using the promotora, the community health worker model, and this is that. And I wish, we would unite and conduct more research to really sustain it, because one of the issues is sustainability. We can only do this through advancing a research agenda. But I think the peer recovery model has a lot of potential to engage, to create trust, to even help us with the hard task of advocacy and implementing a human rights-based agenda. So, but as Corrie said here, we also need to start with moving the research agenda forward. And I understand that we need to do things now, but there is this beautiful model that's called community-based participatory research, right? Where you engage communities, entire communities, and you kind of sign a contract with the community. You say, I'm the PI of the study, but I promise you that at the end we will translate some of the findings into action. And I think, you know, that is it strikes a balance between the lengthiness of research, but also serving the community at the same time. And it's something that we could do with the peer recovery model to understand effectiveness.
I imagine, Corrie, that's happening at Harvard.
Yeah,
In a big way.
That was fantastic. You can tell she runs a lab. You know, and thanks for bringing up the research issue. You know, how can we engage populations? She nailed it with the peer thing there. You know, and when it comes to research-based, you know, in sciences, we know that we struggle with representation in clinical trials, and that has cost us hundreds of billions of dollars. However, underrepresented populations in clinical trials aren't necessarily underrepresented because they're unwilling to participate. The evidence is clear. Non-white populations are no less likely than other groups, and in some cases more likely to participate in research if asked, according to the National Academy of Sciences. But, you know, when it comes to science, unlike workforce issues and diversity, where we had these DEI firms, diversity, equity, inclusion, kind of sprung up with systematic plans to change the course. Science is not as systematically guarded, meaning we need training for all federally funded principal investigators on racial literacy in science as part of their ethical training, and that's missing. For example, how do you identify the presence and degree of scientific racism in a body of research? And why is that needed? There is a legacy of both historical and contemporary abuses in medical research, and times when research was done without therapeutic intent or consent. And there's ongoing issues with scientists misinterpreting the meaning of race in science and concluding biological differences from a socially derived variable. The conflation of race and genetics is one way that racism persists in medicine and science. And some scientists have stated that Black patients, adults and children, are receiving less pain medication because of biological differences, and failing to offer racism as a reasonable interpretation for the study findings. Such conclusions lead to policies and practices and further reinforce scientific mistreatment for people who clinicians identify as Black. And so training's needed on modern interpretations of scientific frameworks that acknowledge inequities all around. Scientists have failed to articulate guidelines for when we use the race variable in a study, that should be put into practice in medicine. You know, one insertion of race into medicine involves diagnostic algorithms and practice guidelines that kind of adjust or correct their outputs based on a patient's race or ethnicity. And physicians use these algorithms to propagate race-based medicine. And many of these algorithms guide decisions in ways that may direct more attention or resources to patients who identify as white as opposed to non-white. So reversing medical mistrust and increasing clinical engagement is going to require systematic training for principal investigators on racial literacy in science. Thank you.
That was excellent. Thank you, Corrie. I've been informed that it's time to turn it back over to Robert. I can't believe the time just vanished like that. But Robert, back to you.
The time does go by so fast when you're having fun and learning a lot. Thank you, Sean, Corrie, and Julia, for your thoughtful commentary and insight this afternoon. We are so appreciative of your time. This does conclude this breakout session on interventions for treatment and recovery stigma. We will now be taking a 10-minute break before our innovation session, which will kick off at 3:20 Eastern Time in the plenary track. As a reminder, instructions for claiming continuing education credit will be provided at the conclusion of today's summit. It has been a pleasure to host you this afternoon. Please enjoy the rest of the summit programming if your schedule allows.